Welcome welcome everybody to today's webinar, Navigating Uncertainty with Improved Payer Contracts and Negotiations. We are going to get started in just a few seconds here as people dial in and settle in, and then we'll start with today's session. All right, well, let's go ahead and get started. Today's session is a panel discussion, and we have brought together 4 experts from managed care to talk about today's landscape in healthcare and how we can improve our payer contracts and negotiations going forward. So I will start off with some brief introductions, and then we will continue on with our panel questions. So my name is Brad Josephson. I'm the Director of Marketing here at PMMC. PMMC is a leading provider of revenue cycle management software and solutions. We have about 400 hospital and health system clients across the country. Also joining me today from PMMC is Greg Kay. Greg is the Senior Vice President of Revenue Strategy and has been in healthcare for 30 years and has been with PMMC for the past 20 years. Welcome, Greg.
Thanks, Brad.
Next up is John Collier. John is the CEO and founder of Innovative Managed Care Solutions, and John brings more than 25 years of experience in managed care contracting. Welcome, John, and can you tell us a little bit about the types of clients you're working with today, John?
Sure, and thank you very much. I very much appreciate being on the call today. I work strictly on the provider side of managed care, so work with hospitals, smaller hospitals, as well as hospital systems and physician groups. And again, only on the provider side.
Excellent. Thanks, John. Next up is Patty Whitmarsh, and Patty is the Director of Payer Strategy and Managed Care at Augusta University Health. Welcome, Patty, and can you tell us a little bit about your role and a little bit about Augusta University Health?
Sure will. I'm delighted to represent Augusta University Health. I've been working in the managed care field for almost 25 years. Always on the provider side, doing a variety of things, including managed care contracting for all types of entities. While at AU Health System, let me tell you a little bit about it. We, on the medical side, are a 478-bed medical center that includes 154 beds Children's Hospital of Georgia, with 15 beds for pediatric ICU. And additionally, on the physician side, we have about 80 outpatient practice sites with about 600 practitioners serving in those locations. We are a level 1 trauma center. And on the university side, as of fall of 2019, we had over 9,000 students from undergraduate to postgraduate studies. And many of those professionals also teach in the university and serve clinic time, so they're treating patients as well.
Excellent. Thank you, Patty, and thank you for being here today.
Thank you.
And last but not least is John Montaigne. John is the CEO of Creative Managed Care Solutions, and John brings over 30 years of experience in healthcare. John, welcome, and can you tell us a little bit about your role at Creative Managed Care Solutions, as well as the hospitals you're working with today?
Sure. Thanks, Brad, and appreciate the opportunity to participate. My background started out, I'm an orthopedic PA by original training, got a business degree while I was practicing, and actually started out on the payer side, in the business side of our industry. So we use that. One thing about our firm is everybody in our company has been on the payer side. What we try to do is to create innovative solutions based on facts with deep analytical skills, bring that forward to build a better relationship between the payers and providers. We also only serve hospitals and their related entities. We work with clinically integrated networks, health systems, and their related physician practices. And so in the various markets, we work across the country, and we get to see a lot of what's going on sort of trend across. So it's quite an interesting perspective that we can bring to help our clients.
Excellent. Thank you, John, for being here. And with that, we'll continue on. So just a brief overview of really what's happened over the past couple of months, really a historic past couple of months, really across the world. And as a result of this, we've seen an unprecedented impact on revenue at hospitals across the country. And as a result of canceled and postponed procedures, analysts say that patient volume has dropped by more than 50% between March 1st and April 15th, which equates to hospitals nationally losing more than $1 billion in net revenue per day. So this leads us into our first panel topic of discussion. And let's turn to our panelists for some recommendations. So considering this historic significant drop in revenue, one, how are we addressing this with our payers? And then two, what types of tools can revenue cycle and managed care departments leverage to monitor payer activity and reimbursement? John Montaigne, let's start with you.
Well, as I said, we try to improve the relationship based on fact-based analysis. But the first thing is the underlying relationship. If we can have an open dialogue with the payers, we understand we're all in uncharted territory here. So, we can ask. A lot of the payers have said that they're having that they've relaxed things. I just saw a notice from Centene that they're waiving co-pays and deductibles and all that. What's that mean for our clients? What's that mean for you when you're trying to help your patients, their subscribers? And then, despite what they say, you got to monitor what's going on. So use those tools that you've invested in to see what's coming through in your data. We can't resist the opportunity to remind them of all the cash that they're not spending because you've foregone all those elective procedures. We're getting a little pressure from the payers to, if we have any open negotiations, and we have several, to kind of hurry and close the door so that they can wall off their risk for those procedures that are those pent-up procedures. We're also seeing that there's a lot of essential care that's being foregone. So, we're reminding them, hey, there's a lot of stuff that's changed right now, but we have to be aware of the changes in the data that we're all going to be seeing going forward. We have a couple of relationships where there's risk based on quality metrics. Well, those metrics are going to be out the window for this next quarter, so we have to be aware of that. And in regards to your second question, again, we try to keep the lines of communication open, even if there's a tough conversation going on. We track the administrative friction. Won't be able to see it necessarily in real time, but within another 15 to 30 days, you're going to start to see, did they really follow the press release that they gave, and did they relax those restrictions, or are you still getting banged for pre-certs and authorizations that supposedly weren't required? Those are going to end up in your data, and that administrative friction is expensive. So again, we try to measure it and quantify it. So and then the other thing is I've sent out a broadcast early on when the payers started coming out with their requirements, suggesting to our clients that they make sure that they contact each payer, their significant payers, and make sure that they understand what the new requirements really are and document what they were told. In fact, see if you can get it in an email or in writing. But again, this is going to be an ongoing situation, so we're going to have to true things up here in a while, and it's new territory for everyone.
Thanks, John. And let's turn it over to John Collier. What are your thoughts on this? Hey, John, we can't hear you. You might be on mute.
I apologize. I was. I didn't want you to hear the background noise.
Okay.
I'm sorry. We, obviously reaching out to the payers for any COVID-19 cases that the hospital might have, to address addressing it with the payers. But, without elective procedures, a lot of hospitals are really hurting on this. And, I think I saw a study that 395 hospitals treated 71% of the COVID patients. So that leaves about 5,600 hospitals that nobody's in house. And all the elective procedures and the physicians, it leaves people hurting. I also saw that, the $12 billion in payments that went out in mid-April or so, a quarter of that went to 25 hospitals that were almost exclusively in the Northeast. So I think we're going to see a period of probably consolidation again. You're going to see hospitals, being purchased by the big boys, and it's obviously a tough time. As far as the second half of your question and the tools, give a plug to PMMC. This is a great time for you guys. Not that every dollar doesn't count always, but now every dollar counts even more. And following up on that, making sure that you're paid appropriately. And, again, as John had said, as the temporary fixes went into place, and, like for physicians, maybe they're paying a normal 99213 for a telehealth visit. Payer systems typically, in my experience, don't always get changed that quickly. So I think following up and, making sure every dollar is even more important to you, I think, at this point in time. So, the tracking of denials and underpayments, perhaps opportunities to negotiate new contracts. I know a lot of the hospitals that own physicians that I deal with are looking to renegotiate a contract so that they are paid for a telehealth visit the same way they're currently paid for an office visit, which some of the payers have done, at least on a temporary basis, but kind of take those specific codes and renegotiate them. So it's going to be an exciting time.
Great. Thank you, John. And then how about you, Patty? How are you addressing this at Augusta?
Well, first and foremost, it is essential to have an ongoing productive relationship with the payers. And we believe that we have that. Initially, before the payers even started distributing their information, we took a proactive approach and sent a letter to all of our contracted payers requesting, if I can use that word, waiving of pre-cert, pre-auth requirements, and we were prepared to cite force majeure if necessary. And then we continue to monitor the flow of information from the payers. We've all been inundated with emails and notices that have come from payers regarding their internal and external processes throughout this pandemic. Then, with regard to your second question, we worked closely with the governor and with the National Guard as one of the leading testing sites in Georgia. And during that testing process, we did not collect insurance information, so the testing was done without an expectation of payment at that moment. We assigned in our claim systems, our patient accounting systems, specific payer codes to those accounts so that we can track them for potential reimbursement later, perhaps under the CARES Act or other opportunity for some dollars coming in. And also we collected and monitored information from the payers, regarding those actions and able to distribute that internally. So everyone knew what was going on with the individual payers. Then, under normal circumstances, and when we did have cases that went on during the pandemic, whether it came in through the ER or was some sort of urgent procedure, we use PMMC variance reporting to trigger our action when our expected payment is not what we receive. So, we have triggers in there to catch things when our reimbursement is not as expected.
Great. Thank you, Patty. And then, Greg, what are your thoughts on all of this?
So, I think, Brad, the panelists have raised some great points as it relates to how the payer-provider relationship have changed. I heard the word relationship several times. I think it's always good to remember that we're dealing with people, both in terms of healthcare services as well as the relationship that we have when we're negotiating contracts and administering contracts. I like the term that John used in terms of administrative friction, and the importance that John and Patty both noted in terms of documenting and monitoring and just having proactive communication. All those components really do tie into having relationships that are based upon data, as John Montaigne noted. Is Brad, as you covered, and as John Collier noted, the revenue impact from this national epidemic has really been significant. And, based upon the data, I think that everyone is seeing and living through, we're not going to be able to go back to the way things just previously operated. And just as payer contract terms will have to continue to evolve. One of the things that we recognize, and I think our clients certainly are recognizing more and more so, is that payer scorecards and the related benchmarks are going to have to continue to evolve. As the panelists noted, there's the importance of not just monitoring volume, because it's down. It's been down and it's now skewed, as was noted earlier. So it's going to be important to monitor the accuracy of reimbursement, because volume is down and we need to collect every dollar that's out there in terms of variances. So the impact that was noted in terms of pre-authorization, denials, contractual variances in a single snapshot report, such as the one on the left, becomes more critical. But additional scorecards in ways we look at payer activity, it's really going to need to incorporate and integrate the actual payment source, and that being the primary payer or the patient member. In other words, as we're negotiating our discounted rates as we go through the negotiation process, we should also be looking at and really monitoring who we're actually collecting from, and where those collection variances, if you will, do take place. And in the examples here, we should be looking at denial variances, underpayment variances, the patient portion variances. We're going to have to be looking at, how are our payers performing in comparison to each other, but also where are those additional revenue recovery opportunities, and incorporating, again, that patient piece in the underpayment obligation, along with our traditional denial and contractual variances. I think as several of the panelists noted, service lines are going to need to be measured and analyzed in similar ways to what we've done with payer scorecards. Trend analysis definitely leads to better insight, which should be used to lead us to improve negotiations. So, as an example of this, if we look at the report on the left side, we can see that with United, and this would be a real example where United's volume is less in terms of activity. Blue Cross is the highest in Medicare, in this particular case, Anthem, and then United. But it's interesting to note when we start looking at where underpayment variances are occurring, the patient portion in this example is fairly consistent across the payers, except for United. And that leads us to then start to drill into the detail to really look at service line opportunities. So when we go down to the bottom right-hand side and start to identify where are those patient portion variances really occurring, where are higher impacts, if you will. In this particular example, this data set, orthopedic services is an area that experienced a higher shift in patient balances. So what's coming in to light more and more, I think, as we go forward, there are times where we think we have better contractual rates and terms, but they may be offset by the payer's benefit plan shift to higher patient responsibilities, and in turn, potentially lower cash collection rates. And this is a good example of how, going forward, charges and the effective discount rate is going to take on a different meaning as we continue to migrate more towards price transparency, especially at the business line or the service level. So when we start thinking about documentation and we start thinking about scorecard reporting, we're going to have to start to incorporate other data elements, such as the patient portion, as a comparative metric. One other piece that we are seeing, Brad, is hospitals looking at new ways to benchmark their activity. And we do see organizations moving towards wanting to incorporate a Medicare reimbursement calculation as a new baseline comparison to really calculate and understand not only what is my expected reimbursement with the affiliated payer, but what's that account, that service, going to be reimbursed under a current Medicare methodology. And we're seeing this shift, if you will, so that organizations have really better insight with operational performance using a Medicare relative comparison. So it's just important to note as we kind of think about where we are and managing those relationships and those administrative frictions and being proactive in our communications, that we start thinking through, do we have the right payer scorecards in place to really administer and manage those relationships? Okay, Brad.
Thank you, everyone. I apologize, I was still on mute there. Thank you to all the panelists for your thoughts on that topic. And we will move on to topic number 2, which is the recent increase in telehealth. So with the required social distancing requirements, one of the immediate and potentially long-lasting trends with the delivery of healthcare services has been telehealth. So how do we see healthcare providers and payers approaching the immediate migration to telehealth? And how will this potentially impact hospital reimbursement and payer negotiations? Patty, what do you think about this?
Well, through the pandemic and all of our COVID testing, we expanded our telehealth services via an application called Express Care, where patients can actually log in and speak directly with a healthcare provider over their cell phone or computer. And actually, it was very convenient. I used the service and was very pleased with it. And, again, it doesn't collect insurance information, so that didn't help us from a financial perspective. We do understand that hospital reimbursement has taken quite a hit. And as we continue to work through that, we don't think that there's going to be much of an improvement until things return to what I guess we'll call a new normal. We are already scheduling procedures, and with the state opening up last week, we expect to continue to do that. In fact, I heard this morning on a call that as of now, we are very close back up to where we were prior to the pandemic with the request for procedures. One interesting outcome I do want to mention is, and all the hospitals have seen this, is the huge vacancies in the ER departments. And, we've tried in the state of Georgia over many, many years to have improper use of the emergency room shift from caring for colds and sore throats and earaches. Apparently, it takes a pandemic to do that. So we've lost, the number that I received from our analytics was about 42% drop in ER throughout the last 6 to 8 weeks. with regard to how it impacts our future negotiations and maybe even potential negotiations that we haven't thought about undertaking, is that we kind of expect, or at least I do, some patients who have had their initial experience with telehealth thrust upon them that would have had a positive experience. And those folks of us that stay busy, I expect it will become a preference, and that it's going to be important for us to make sure that we include reimbursement for telehealth in our contracts starting now and going forward, because I don't think that's going to change. And additionally, we're going to have to make sure that, maybe not all services are appropriate for telehealth, but let's make sure we can meet the patient's needs through the telehealth environment while ensuring that the reimbursement that we receive for those services is appropriate.
Great. Thank you, Patty. John Montaigne, what are your thoughts on this?
Well, we've got a couple of different perspectives on it. We've had existing telehealth programs established for some time, 3 or 4 years with several payers, and so it's sort of a payer-specific response. With those that we have existing relationships with, we've focused on expanding and enhancing the relationship and deploying it in more places. I mean, it's a cost-effective solution for all. And then discussing with them, we talked earlier about where we sort of have a relaxed set of regulations now. Well, when does that change? And to John Collier's point, the machinery that payers operate on, these are some of the insights you get when you work for one, is that machinery hasn't changed. So they have not changed their algorithms or their other stuff, most likely. They've just put out a press release. So you're going to have to talk to them about, okay, when you say this, but you do that, then we have to be able to pull it. We call them buckets. We put the issues into buckets so we can prioritize how many times it's happened and what the cost is. And then and for those payers where we haven't had a relationship in telehealth, let's see if we can move them down the track. I think this is going to be, we view it really as an opportunity. So we want to try to establish and upgrade the opportunity for them. And then going forward, again, we see it sort of as an opportunity to collaborate. We've asked some of the payers to foot some of the bill for the infrastructure spend that's required on our side. If not, we need to make sure we cover that in the reimbursement rates. At the end of the day, you've got a very expensive system that we're being asked to provide to take care of our communities. So they're getting the lion's share of the profits from this, as they report every quarter. So let's see if we can have them invest in our communities and help us with putting the infrastructure out there further, so that you have a more leverageable footprint in your market. And then to Patty's point, I don't think we're putting this genie back in the bottle. The clinical efficacy, the safety for both staff and patients, the cost effectiveness, the ROI you can get from the investment, and then just the customer satisfaction. Patty gave a personal example of how convenient it is. So I think this is, I've seen, I shared with a client the other day that one of the health plans that we work with has gone from like 5,000 visits a year to 74,000 a month now in telehealth. This is, if you're going to serve your community, this is going to be an essential tool. So we need to get the payers to pay for it.
Great thoughts, John and Patty. Thank you.
Brad, this is John Collier. Could I just add a couple things to those wonderful comments? And, that would be, my experience getting a physician to change the way he or she does something is kind of like turning a aircraft carrier. So I think it'll be interesting to see if the docs want to stick with it. And I think there's also the residual, what's going to go on with malpractice lawsuits, what are the attorneys going to do after this is over? And, we are back on a more normal time frame, and how will that affect how much telehealth we can do, and et cetera. Just a couple of thoughts.
Yeah, Thank you very much, John, for adding that. I think that's an important part of the conversation. Let's move on to talking a little bit about the transition to value-based reimbursement. So today there's obviously a big national focus on testing and tracking and those types of things, you know, in order to really keep our population healthy. So how do we see the COVID-19 virus potentially impacting a move toward value-based and population health reimbursement as opposed to the procedure-oriented reimbursement, like getting paid for maintaining health versus only being paid for activity? John Collier, let's start with you.
I'm on mute again. I didn't mean for this to flow quite like this, but as I said, you know, getting physicians to change the way they do things is oftentimes a bit of a struggle, but obviously it will happen. And, you know, also value-based things I think work best if you can get some alignment from the payers. I mean, you know, if you have, you know, 10 elements that Anthem wants you to do, or Blue Cross, and then there's a different 10, or, you know, that United has, and yet a different 5 or 10 from Aetna, you know, the docs just can't really get with that, at least in my experience. You know, so I think either to have some uniformity from what is being monitored, or, you know, perhaps you can, you know, only choose a few payers. Maybe, you know, if you're in the marketplace where you can do that, and say, you know, okay, this system's going to contract with these folks, but not these folks, and move your population to that. So, you know, I think those are a couple of things. And again, you know, as I probably mentioned, I think this whole thing is going to be an opportunity for some different kind of contracting, and, you know, perhaps there'll be opportunity for people to even go to more risk-based contracting, and not necessarily full risk, but to, you know, to go down that road and some different avenues for providers.
Absolutely. Thanks, John. Patty, how about you? How have you seen value-based at Augusta?
Well, I think that payers definitely love the idea of value-based contracting and sharing the risk with providers. And it's been slow to creep into Georgia. We do hold a few value-based contracts, and it seems that the payers honestly haven't been quite as operationally ready as we have been. We've had some difficulties with making sure that the attribution lists are correct and that type of thing. John brought up a really good point, having uniformity between the contracts, making sure that it's easy for us to track which things we are being monitored on, and that's going to be essential to make sure that we do what we need to do to keep our communities healthy. Your second point, I think, is as we move forward, I won't be surprised to see the virus and antibody testing show up on the payers' quality measures, that they expect us to make sure that our folks are healthy in order to receive some additional payment, much in the same way, you know, immunizations are on there, flu shots, mammograms, et cetera. So I think we're going to have to be watching for all of that and making sure that we can fulfill those obligations and track things appropriately.
Great points. Thank you, Patty. John Montaigne, any additional thoughts that you thought of while John and Patty were giving their responses?
Yeah, they both brought up very good points, but we tend to be more offensive than defensive. There's certainly challenges. So where I have the executive and clinical leadership in an organization, and there is an opportunity, they have a leverageable footprint, and they're an appetite to serve their community that way. You know, the payers, when I say payers, I'm thinking more employers at this point, employers and consumers, they're looking for good value. And so if you can demonstrate that value, and to John's point, in a couple cases where I've got competing payers, you know, with different metrics, well, those are payers that set up the metrics. We ask our clinicians to set up what are reasonable clinical metrics that we agree to be measured on. And you all, if you're going to be part of our deal, you know, those are the ones that we want to work with. And then, you know, so we kind of pick and choose our payer partners based on their capability to work with us and be flexible. So I think there's a huge opportunity if you look for ways to demonstrate and measure the value that you can bring to your community.
Great, thank you, John.
John, that's particularly true if you have a clinically integrated network where you're already measuring, you know, outcomes and what have you.
Well, and to add on to Patty's point about the payers not really being ready, there again, it's a press release. They have made a ton of money in the fee-for-service world, chipping away at everything we do when you line out a line item bill. But when you do real, I mean, I cut my teeth on the full cap side. I didn't realize this fee-for-service existed when I started on the payer side a long time ago. So I was brought up with full capitation. The payers say it, but they don't have the infrastructure or the staff that knows how to work it. But that has to be driven by your clinicians, because that's the only way the model works.
All great points. Thank you. Thank you, everyone. Let's shift gears a little bit into our next topic, which is on price transparency. So this is really a two-part question. So the first part is with the migration towards transparency and consumerism with online shopping and comparative shopping, how will this shift impact payer contracting going forward? And then the second part, if the goal of all of this is to lower the cost by providing patients with options to seek out the lowest cost of care, how would this potentially affect hospitals in terms of offsetting, potentially reducing or reduced revenue? So let's start with John Montaigne. What are your thoughts on this shift?
Well, interestingly enough, this is sort of where Greg and I met. He was giving a presentation at North Carolina HFMA, and we got to talking, and his presentation is really a valuable service to hospitals. You need to start to get ready because there's no denying that this is coming. You know, back to the conversation we just had about value-based, you know, employers are just at wit's end. You can't shove any more cost onto the employee, and the health plans that are run by state and government officials are just strapped. So we're going to have to be accountable, and the payers are busy trying to hide things. So we're going to have to put our money where our mouth is, and say, if you think you're that good, then you better demonstrate it. So there's a couple different ways to do it. Greg actually has a great presentation on what's required to comply with the federal regs, and you better not plan on them getting postponed. So, but basically, this is where the relationship really comes in. Again, we look at our payers as in a portfolio, and there are some that are better to work with than others. We try to focus on those that we can work with and say, look, we are in this together. You sell our services to our community. How can we do this cost effectively? And you can't keep all the money that we save, you know, when we cut the amount of services. But in every situation where you have centers of excellence or any other kind of, you know, bundles are sort of baby steps on the road to full cost of care. And essentially what you have to be able to do is quantify how you care for that person, not over a bundle, but over the year. So if you can demonstrate that you can lower the spend for an employer, you and the employer need to get the lion's share of that, not the payer. So we actually have built out models for to facilitate that, but you can only work with, I mean, you're going to need cooperation there unless you're going to stand up your own plan. You're going to need collaboration with some payers to go after the different markets, and then pick and choose your strengths and what you want to, how you want to serve your community.
Thanks, John. And John Collier, how about you?
That darn mute button. You know, I think hospitals and all providers need to explore new revenue opportunities. Again, it might be risk, might be partial risk. It's going to be a bit of a new world. As far as cost cutting and what have you, a hospital can only go so far. And most of the facilities I work with have certainly, they've cut staff, they've even cut services in some opportunities, and you can take it so far. And then, of course, the other side of this that always gets me is you still have an attorney standing at the door waiting to sue you. And, some of this, I think we need to see some malpractice reform.
Thanks, John. And Patty, I'll turn it over to you. How is this impacting Augusta?
Well, first, let me add on to what John Collier said. Hospitals can not cut prices in any more significant manner. There are only so many additional efficiencies to be obtained, and I can't imagine that any hospital isn't at bare bones already. So as we look at the shift in impacting the payer contracting going forward, I think that we're going to have to look at what are our profitable service lines for larger institutions like AU, providing unduplicated services, negotiating appropriate reimbursement for those services, and expanding into areas geographically that have a more profitable payer mix. At the end of the day, hospitals can't expect that we can provide everything to everyone. Some services will undoubtedly go to a lower cost provider. While hospitals have to maintain a 24-hour ER, there's certainly other places where people can go that's less expensive. People are going to shop. There are certain hospitals, like teaching hospitals, that have higher costs because we have this teaching section of our institution. And, we try to pass those on to organizations like Medicare, but what we see is a lot of payers want to carve those out, especially the Medicare Advantage payers. They want to carve that out of a contract. We have to consistently argue on that. So it's going to be interesting to see where we end up. But again, we've already seen a lot of services being carved out or cherry picked, if you will. Lab work, radiology services have already been steered to a lower cost place of service rather than at a hospital setting. So we may just have to decide we can't do everything. We can't provide every service to everyone.
Great points. Thank you, Patty. And before we move into our final topic on analytics, I'm going to make a quick call for any questions that anybody has. Go ahead and enter that into the questions tab in your GoToWebinar panel, and we will have a few minutes at the end to take any audience questions. So if you can think of anything from anything the panelists have said, go ahead and enter those, and we'll be happy to answer them at the end of the presentation. So our final topic is on analytics to better forecast and manage revenue. So with all these shifting dynamics going forward, what types of analytics and reporting are hospitals and health systems going to need to manage all of this in order to forecast future reimbursement? Greg, what are your thoughts around this?
So as we think about, Brad, the question is future reimbursement, and I'm coming back to the payer scorecard that we were looking at a little bit earlier. We obviously all know that payer contracting and actual reimbursement is a dynamic process. It's a cyclical process. We go round and round at times with the payers. So to your question, Brad, effective and efficient analytics and forecasting of payer contractual reimbursement really has to start with the right payer scorecard. to know how the actual performance is occurring and where changes can and should occur. I think both John and Patty brought up excellent points as it relates to, in many areas, hospitals are reaching the point with certain service lines of being at that low cost end. And there's even, steerage that does take place even to lower cost of care locations. So it's getting back to that foundation of your payer scorecards and really knowing what can and cannot be done. Really understanding that at the service line level becomes critical. And as John Montaigne noted earlier, just making decisions that are data based becomes more and more critical. So, with efficient payer scorecards, you're going to really need to look hospital specific to determine what your baseline metrics are going to be, how your payer contracts themselves are performing in comparison to each other at particular moments in time, as well as over time. And one piece that often gets missed that we find is really how are payers performing to the initial projected contract model when you're negotiating the actual contract. In other words, what was the projected yield when we finalized our negotiations with the payer, and then monitoring back to how is our actual yield in comparison to that projected yield, and why and where are those variances occurring? Is it steerage? Is it whatever? We have to know those where and why questions as we go forward when we start to think about forecasting future reimbursement. Brad, back to your question.
Right. Thanks, Brad.
So as we move forward, one of the other questions that we touched on a moment ago was price transparency. And I think one of the pieces that we have to start to really get our head around as an industry is our healthcare services going to be price shopped. And we as an industry have typically viewed there not being price elasticity in the services that we provide. There really hasn't been shopping of services based upon price. There may have been steerage, but not necessarily price shopping. In other words, are consumers going to go to where they find a better deal, or are they going to continue to go where they're directed, whether that direction is by the healthcare professional or the payer? I think most individuals have relied on, historically in the past, and believed that healthcare professionals had their well-being, both their physical well-being and their financial well-being in mind when we said, hey, go here for this particular procedure. With CMS's focus on increasing price transparency, and really with the national pandemic, consumers will have a new expectation of what they can find online. I think we're also finding that the public has had more time to research. They're now becoming more accustomed, as it was raised in the question earlier, they're becoming more accustomed to telemedicine services. They're more accustomed to scheduling online, paying online for healthcare services. And they're going to want to know more immediately how things compare from a price standpoint. So as we revisit our payer scorecards, it's going to be important that we also include in that monitoring process where services are being shopped, which payer segments are shopping more or less frequently, what's the impact on volume, and what's the impact on revenue. Those are going to have to be incorporated into our scorecard process. We're also going to have to take into account how do our prices really compare in the marketplace, because we may see a shift in volume, but we may want to really understand if our price is already less than the competition, that steerage may not be due to price, it may be due to something else. But if our price, being the negotiated rate, the patient portion, is higher, that's going to be a new variable that we're going to have to take into account as we look at our services. So, as the panel noted, our approach to payer negotiations are going to have to continue to evolve. And one thing from a prior webinar session and survey that we did last year, Microsoft and Excel and Access were noted as being the primary tools that hospital executives were still using for their contract negotiation process. And as similar to the scorecards, our modeling process is going to have to include a more detailed understanding of those reimbursement gaps and some of the challenges that John and Patty noted on the call today. We're going to have to think through, where are we collecting every dollar that's out there? Are there contractual variances, denials, patient portion gaps that we need to consider as we're negotiating our future contracts? And it's also going to be important to integrate cost. Some organizations do have actual cost accounting decision support tools. A lot of organizations don't. So we should be looking to incorporate, at least at a bare minimum, an estimated cost value using a ratio of cost to charges at an overall global level or down to the detailed charge code level. Either way, we should be looking at and really understanding, back to Patty's point earlier about we may not be able to do everything. So we're going to have to really understand what's our margins on the services that we do, to know really how do we position ourselves in that negotiation process. And with the prior question, there was a slide that Brad had on the screen as it relates to price transparency, and there were two young adults there with iPads, and we have to recognize that with the growing consumer focus on their cost, we're going to be thinking through, and we're going to also need to model not just our projected reimbursement, but we're going to need to be looking at how do we model lowering charges in some cases and taking into account lesser of contractual language, taking that into account so that we're making well-informed decisions based upon the data on a go-forward basis. So, the key point that I think the panelists have all highlighted is that reimbursement's only going to get tighter. Payers, as we know, the last 10, 15 years have only gotten larger. Negotiations have only become more and more challenging. And it really translates to having the right integrated tools with the right data for your facility to meet both the current and the future challenges as we go forward.
Excellent. Thank you, Greg. And thank you to all of our panelists. And as we wrap up today's session, let's go around the horn and get some final thoughts from our panelists, and then we will open it up for questions for a few minutes. So, John Collier, any final closing thoughts for today?
Listening to what I'm not muted this time. Listening to what Greg had to say, I would just kind of piggyback a little bit onto that, in that what also comes into that is your payer mix. And if you are in a town, or if you're 25 miles from a town that has a much richer commercial payer mix than you have, obviously, everybody uses a commercial contract to cover what they don't make in Medicare and Medicaid. And, if you're in that position and a hospital 25 miles away is not, elective, you can drive 25 miles for an elective procedure. I mean, my gosh, there's plans out there that want you to go to Taiwan for a knee replacement. So, I think that's just an additional challenge that will continue, and it's been there for a long time, will continue to come through, though.
Great. Thank you, John. Patty, how about you?
One last point that I'd like to make is one that I made early on, which is we must have a very good relationship with our payer contacts. That everything we do is going to hinge on that. We must make sure that as we enter negotiations, I agree, we've got to have appropriate data, and to be able to explain that to our payer and have them look at their data and see if they see the same thing. Additionally, you've got to meet with them regularly. We meet with our major payers at a minimum of quarterly, and those that we have risk relationships with, it's monthly. I mean, we have to have that regular ongoing connection with them to be able to work through any issues we have. So that relationship is essential.
Great. Thank you, Patty. And John Montaigne, closing thoughts from you.
Well, to amplify all the conversation we've just had, one thing that we try to bring to our clients is a strategic perspective. And I say that both from a payer relationship perspective as well as from a client capability perspective. So who are you and what market are you in and what services do you seek to provide to your community? And then which payer relationships help you do that? These are dynamic processes, and you know, when we use these tools, we're looking backwards. So we've got data that tells us what the history is. We take your data and build these models dynamically so that you can take them to the C-suite or the board and say, okay, this is where we are now. Over the next 5 years, where do we want to serve our community? And then with those capabilities, you can model in, okay, we're seeing this trend in our community, so we need to provide these services. You can build those into the models, but we do a forward-looking model to say, okay, what's this going to produce over the next, you pick the time period. But you got to remember, we're looking at data, and a lot of us have analytical financial backgrounds. We're looking backwards. So we need to, and then with that, which payer relationships and whose products. United's just now decided that they're going to come back out into the exchange market. You know, they left us high and dry in the markets that they couldn't make money in before. And now all of a sudden they see an opportunity to make money, they can come back. We can't leave our communities. So you've got to have a perspective of how are you going to serve your community, and then use these tools to think about strategically, how are we going to compete? And to Patty's point, you know, and both John and Patty's point, we can't cut anymore. We got to figure out where we strategically invest. And part of those investments is our investment in these payers. I know CFOs think that they have to have every contract in the book out there, but product by product, we try to refine, much like you would your stock portfolio. Okay, who's going to help me get to my goals? Which companies or which health plans and their products are going to help us serve our community best? And you've got to have a forward-looking compass on that. So we use our models dynamically to try to produce scenarios that you can build in so that the community gets served in the way they're going to need to be served.
Great. Thank you very much, Sean, and thank you to all of our panelists. And I know we're coming up on the hour here, but we'll spend a couple more minutes just going over some questions from the audience. And if anybody needs to jump off the call, we completely understand. But those that would like to spend a couple more minutes with us, we'll go through a couple of questions we had from the audience. The first question, and this one I think, Greg, you can answer, is what was the type of software used for those analytics reports that you were showing at the end?
Yeah, Brad. So those were from PMMC's contract management system. So from an application standpoint, we use a SQL database that we use Power BI, Microsoft Power BI as the data visualization layer. But that's the data is aggregated through our contract management system for really all financial data points coming into that SQL database.
Okay, great. And then I think that answered the question. Another one we have is, how often do you recommend meeting with payers to discuss the types of issues that we talked about today? And I'll open that up to any of the panelists on the call.
Well, this is John Collier, and I would say, you know, your major payers where you get the majority, you know, greater amounts of income, I mean, you want to meet with them monthly. some of the, not as popular payers, if you will, or, where you're being reimbursed properly, you probably don't need to have meetings quite that often. But, as Patty had said, I think, the constant communication, there is something to a relationship, and you need to keep that going, in my opinion.
Thanks,
I'd
John.
suggest,
Anyone else want to jump in?
I'd suggest it depends on the strength of your relationship and the issues that you're having. I mean, you're busy enough as it is. If things are moving forward, but if you're having hiccups, then you either need to have more meetings or terminate that relationship. Back to my original comment about you don't need every health plan. You got to understand there's an inherent cost with every contract you hold. If that health plan relationship doesn't warrant the cost of your staff and all the hoops they make you jump through, might be trying to trim your portfolio.
Sure, great. Next question. So numerous payers waived their pre-authorization and pre-certification requirements. When do we see payers moving away from those waivers, or in other words, bringing those back in? When do we see this happening again?
I think it's going to happen very soon. In fact, I received an email this morning from one payer wanting to know when they can send their person in to start auditing charts again.
This is John Collier. I've seen as soon as June 1st.
Maybe it's just a professional skeptic in me, but I doubt that you've seen any relaxation at all. You'll find it in the data in a couple of weeks or so, but I don't think they've changed their machinery. The processes are the same. I would be surprised if they, in fact, just don't wash some of that through, but they haven't changed anything. So I would operate as though it's business as usual.
I agree, John. We're going to see a lot of underpayments in the next few weeks.
Yeah.
Agreed.
Great, thank you, everyone. And we'll take another question here. What's your recommendation for posting pricing information for the upcoming price transparency mandate?
I think that's in Greg's wheelhouse.
I think it somewhat depends on your competitiveness, I think it somewhat depends on how competitive environment you are in and where your prices are. I have talked to hospitals that the fine is not that big a fine, and they're going to wait and see what other people do. On the other hand, I think you can choose what prices you show. So people have talked about, okay, we'll show a bunch of lab stuff. So I think it is somewhat unique to your marketplace.
From the strategic impact, I mean, you're going to have to put your prices out there at some point. Your community, you owe that to your community. The question is how do you strategically use that information and negotiate? It depends on the market. And in some cases, we've literally gone to the payers and said, look, for these commoditizable things, you're already redirecting our patients away. You have a third-party company, a subcontractor, directing people away from us anyhow. Again, it depends on your market. We've strategically decided that those commoditizable services we're going to not put much of a margin on, but you better know that you're not losing money on them, and then we focus on the rest of the book of business. But primarily depends on your market and your position in it.
Yeah, I'll just add to that from the standpoint of recommendations as it relates to posting pricing information. Obviously, if that's the rule, our position would always be we need to follow the mandates. If there are court hearings that are out there that could play in our favor, hopefully it'll play in our favor. But at the end of the day, I think we've seen, especially through the COVID virus epidemic, things are going to be different. Consumers are going to be looking, and they've definitely been shopping more online. I mean, everybody has to acknowledge that. We're going to have to respond. I think we have seen as an industry, we can respond extremely fast. We responded to this situation faster than I think anybody would have ever imagined us responding. So, I think at some point we just have to embrace the fact that the industry is changing. It is a fair request for consumers to understand what things cost. Probably means really putting out there more of an estimation tool that individuals can get a cost estimate than really posting another list of charge information. That's not going to help anybody. So that would be more our recommendation, is to follow the rules and meet the needs of your local market.
Thanks, everyone. And that concludes all of the questions that we have for today's session. So as we wrap up today, I would just like to thank all the panelists for your time today. I think you offered some great points and insight for our audience. And then I'd also like to thank everyone who attended today's session. Greg, do you have any closing thoughts before we sign off today?
Yeah, I would definitely want to echo, Brad, your comments and thank the panel for their time. We're all in this together. We can only get better if we're willing to sacrifice and share our time and our knowledge. And we certainly do appreciate John Collier, John Montaigne, Patty. We appreciate you guys being on the call today and sharing your insight and experience.
Thanks,
Thank you.
my pleasure.
Appreciate the opportunity.
Thanks so much, guys.
Thank you, everyone.
Have a great day.